at Lady Hardinge Medical College, New Delhi, and is also the associate editor of Indian Pediatrics. So over to Dr. Abhijit Shah.
Quickly in 15-20 slides, I would be covering the diagnosis of urinary tract infection, and at the outset I thank the organizers for inviting me for this very important session on urinary tract infection. So how to make a correct diagnosis of urinary tract infection? There are 4 pillars. You need to look at the symptomatology, what the patient is presenting with, extract what symptom the patient is complaining to you. Definitely do a very good clinical examination, so do not miss any overt or covert signs which the child is having. So definitely need to take the patient to the examination table and then examine. Just do not inquire about just the clinical symptoms and make a diagnosis. Also examine the patient. Collection of urine, transportation and storage of urine, and then interpretation of the urine culture report. So these are all required for making a correct diagnosis of urinary tract infection. So we know that around 2% of boys and 7% of girls experience at least a single episode of UTI before the age of 6 years. The incidence for boys is highest during the first 6 months, whereas the incidence in girls is around 2% during the first 6 months. And E. coli is responsible for more than 80% of the episodes of urinary tract infection. Why we are worried about urinary tract infection is that febrile UTIs are associated with renal scarring, and with each new febrile urinary tract infection, the risk of renal scarring is increased by 2.8%. Now, probably for postgraduates and all of us, this is the most important 2-3 slides. When do we suspect UTI? So, many a times younger infants would actually present to you with clinical signs of sepsis, and if we do not send the urine for examination, then probably we would be just starting antibiotics and we would be missing urinary tract infection. So less than 2 months of age, fever, vomiting, lethargy, poor feeding, failure to thrive, jaundice, hypothermia, hematuria. You can just look at if you remove hematuria from here, everything else point towards just sepsis. So they don't localize the symptoms, and it is usually symptoms of sepsis. As the age grows, then some localization to the urinary tract starts, and then depending upon that, between 2 to 24 months, you would have additional, at times, cloudy urine, abdominal pain and all, and more than 2 years, fever, apart from fever, frequency, dysuria, incontinence, vomiting, lethargy, abdominal pain. So very important to look at what the patient presenting. Then again, always examine the patient properly. So any palpable kidneys would be pointing towards obstructive uropathy, any costovertebral angle tenderness towards pyelonephritis. Again, a suprapubic tenderness or a palpable bladder would point towards either an obstructive uropathy or a neurogenic bladder. Palpable fecolith towards constipation, and just asking about constipation at times doesn't help, and I'll talk about it later. Always examine the spine for any sacral dimple, tuft of hair or lipoma that can point towards occult meningomyelocele, and any abnormal neurological evaluation of the lower limbs or any absent perineal sensation again would point towards occult meningomyelocele. A word about bladder bowel dysfunction. So it encompasses the lower urinary tract dysfunction, the what we call as LUTD. So any history of frequency, urgency, holding maneuvers and all would point towards bladder, lower urinary tract dysfunction and bowel dysfunction. would be either a constipation or encopresis. So those symptoms, again, very important to elucidate while you are evaluating. Now, when would you suspect, and why should we suspect about bladder dysfunction, bladder bowel dysfunction? So around 41% of patients with UTI would be having bladder bowel dysfunction, and if we look at primary VUR, around 49 to 50% of patients with primary VUR would be having bladder bowel dysfunction, and that is why very important aspect. So when would you suspect any patient with a recurrent urinary tract infection or a persistent high-grade VUR, constipation, impacted stools, maneuvers for postponing, avoiding, frequency of voiding if it's less than 3 times or more than 8 times a day, any straining or a poor urinary stream. If you have many a times, patient will already come to you with a report of ultrasonography, and in that if there is a bladder wall which is more than 2 mm or a post-void residue of more than 20 mils, or if an MCU is available, then a spinning top configuration would point towards bladder bowel dysfunction. So very important to evaluate that also at the outset so that we do not miss it. Again, especially in adolescent girls, they might not come up with this history, and at times it takes time to gain confidence, and then maybe you can talk to the parents, the mother especially, and then only they would come up with this history. Again, upfront, if you ask about constipation, many a times they would say that no, there is no constipation. What we now, we have started keeping this Bristol stool chart and then showing it to the patient if it's older, or the parents, and then they would say that yes, the child is having type 1, type 2 or type 3 type of stools. So again, evaluating for constipation, very important for making a diagnosis. Now, apart from that, screening of urinary tract infection is also very important. So most of the time now heuristics are available. So there are 2 tests, leukocyte esterase and the nitrite test. So leukocyte esterase is present in neutrophils and can be assayed by the dipstick, and the bacterial nitrate reductase, it converts the nitrite to nitrate, which can be again assayed by the dipstick. So these are the 2 dipstick tests which has got good sensitivity and specificity, and it was seen that either a positive leukocyte esterase or nitrite has got the best combination of sensitivity and specificity. So these tests can be used for screening. Now, bacteriuria in a fresh sample has also got excellent specificity and a good sensitivity. However, again, it will be time taking. So that instantly you might not be able to decide until the report is available. And addition of leukocyturia to bacteriuria doesn't improve the sensitivity, and the specificity remains lower. So either a positive leukocyte esterase or a nitrite has got the best combination of sensitivity and specificity for the screening of urinary tract infection. So it is suggested to use a urine dipstick, either a leukocyte esterase and a nitrite combination as a first line screening test for urinary tract infection, and whenever feasible, a urine microscopy for bacteriuria and leukocyturia in a freshly voided sample. Again, the recommendation is in a freshly voided sample to be examined within 1.5 hours of voiding the urine, and if at all a delay is expected, then the sample can be refrigerated for 4 hours, and that is very tricky at times in busy hospitals, so that needs to be taken into account. Now again, the other important part we always teach our postgraduate, this is probably the weakest link why at times we do not get culture positivity, is the collection of the urine is an issue, more so in younger, less than 2 years of age. So there are various methods by which you can collect the urine bag, clean cat sample, voiding stimulation, the quick V method, catheterization or a suprapubic aspiration. Now there are pros and cons of each of the methods, but overall for non-invasive collection, the clean catch is the method which is having the least contamination risk. If we look at the invasive collection methods, then catheterization has got a low contamination rate and a suprapubic aspiration a very low risk of contamination, and suprapubic aspiration has also, the yield can also be increased if an ultrasound is available in case of an inpatient if you are trying to send a sample. Now there is various international guidelines for collection of urine sample in young children, and most of them they recommend for older children a clean cat sample. You can look at various techniques. Now briefly about the three important techniques: the catheterization, quick V and the suprapubic aspiration. So again, in younger infants, proper positioning and proper aseptic precautions are very important, so that you get a proper sample. A frog leg position of the infant at the time of collection of urine, proper cleaning of the genitals, and then catheterization with a 6, usually it's for younger infant, a 6 French tube is used. Quick V method is stimulation of the suprapubic region after cleaning with a cold solution, cold water. You can instill in a gauze piece and stimulate the suprapubic region, and it is proven that around 25 to 30% of infants would pass urine within 5 minutes of this maneuver. So that is also one of the methods of collection of urine in infants. Suprapubic aspiration, again positioning the patient and ensuring that a 23 gauze sterile syringe is used, and the insertion should be at 90 degree to the skin surface, and that needs to be, if at all you have ultrasound, then better to do ultrasound guided. So again, it is suggested for the Indian guidelines, it is suggested to use the midstream clean catch method for collection of urine in toilet trained children, and for non-toilet trained stable children, on midstream clean catch should be attempted initially. However, if it's unsuccessful, then a urine sample may be collected by either catheterization or a suprapubic aspiration. For sick infants, catheterization or suprapubic aspiration are preferred method for urine collection. Coming to the colony forming unit, the 2011 guidelines, if you remember, the clean cat sample colony forming unit was 10 raised to the power, more than 10 raised to the power 5. So over last decade, lot of evidence have shown that, and the evidence came from the review that those patients where suprapubic colony forming count is more than 10 raised to the power 3, if you examine the clean cat sample of these patients, not everybody would have a colony count of 10 raised to the power, more than 10 raised to the power 5. At least maybe 15 to 25% of these patients can have a colony count which would be 10 raised to the power 4. And so there are other evidence also to suggest that maybe for clean cat sample 10 raised to the power 4 may be sufficient. And there is a recently published article from India also, which proves that by lowering the bacterial colony count to more than 10 raised to the power 4 in a clean, voided and catheter-based urine samples, and additional proportion of symptomatic children with probable urinary tract infection and possible underlying urological abnormality may be identified. And this article was published this month only, where support for again use of new cutoffs to define a positive urine culture in younger children has been studied using the 16S RNA gene amplification sequencing as compared to the urine culture at different cutoffs, and children with more than 80% relative abundance of any of the organisms on 16S RNA gene amplification sequencing with elevated urinary biomarkers of inflammation defined as UTI. And here you can see a cutoff of 10 raised to the power 4 colony forming unit per ml has a sensitivity of 98% and a specificity of 99% respectively. So the overall evidence is, it is suggested that the diagnosis of UTI is based on a significant growth of a single bacterial species on urine culture in presence of symptoms. Again, very important to look at in presence of symptoms, and a growth of a single uropathogenic bacteria respectively for suprapubic aspiration as to more than 10 raised to the power 3, for catheterization more than equal to 10 raised to the power 4, and for midstream clean catch sample 10 raised to the power 4 to 5 rather than the previous guidelines of 10 raised to the power 5 is to be taken. A word briefly about asymptomatic bacteriuria. So again, the asymptomatic bacteriuria, the significant colony count is 10 raised to the power 4 to 5 rather than the previous 10 raised to the power 5 in absence of symptoms. So it is suggested not to use antibiotics for the treatment of asymptomatic bacteriuria, and it is suggested that the routine urine cultures, many times it happens, the child is asymptomatic and at times we find that urine culture is sent again and again and again. So that is not needed in an asymptomatic children, because it is there might be a case of unrelated infection in children where when you start treating it, and there are only specific conditions where asymptomatic bacteriuria needs treatment. So to finally the last slide of the presentation is in a child who is having fever without focus for more than 24, if the child is having a specific urinary symptom, that is fine, but fever without focus for more than 48 hours in a child who is less than 20 months old, 24 months old, in presence of risk factors. The risk factors would be bowel bladder dysfunction, primary VUR or previous history of urinary tract infection. You perform urine culture, send urine culture, and you do dipstick. If either of the leukocyte esterase or a nitrite test is positive, you send empirical antibiotics and you wait for the culture. If the culture is positive, you continue antibiotics. Otherwise, you can stop and consider other diagnosis. And for a leukocyte esterase negative, you continue empirical antibiotics only if the age is less than 6 months or there are risk factor present, and then you wait for the culture and then you decide. So I think this was my last slide. Time is up.
Thank you, Dr. Shah. I think we should take up questions and comments after. You can.
Thank you so much, sir. Now we will be heading towards on panel discussion based on real case scenarios on imaging in urinary tract infections. That what are the new guidelines, what has been changed from before, and why it is needed to be upgraded and updated about the imaging modalities. So I would like to invite the panelists, Dr. Subal Pradhan sir, Dr. Alpana Ovi and Dr. and the panel discussion will be moderated by Dr. Sudha Ekambaram.
On over to the imaging urinary tract infection. How have the guidelines changed and why? And we have the current guidelines in UTI being revised, and it is accepted for publication in the pediatric nephrology, and it will be shortly getting it online, and this is being headed by Pankaj Hari sir. And we have three eminent panelists with us. We have Dr. Subal Pradhan, who is the Associate Professor from the SCB Medical College at Cuttack. And we have Dr. Alpna, who is the Professor in Pediatrics and Pediatric Nephrology at Wadia Hospital in Mumbai. And we have Jitendra with us, who is the Assistant Professor from AIMS, New Delhi. So going on to the we have Dr. Abhijit Saha has clearly explained to us that the diagnosis of urinary tract infection is by a good history, physical examination, and a lab investigation with a good urine routine and a culture. Imaging helps us to identify the malformations on the urinary tract, like the vesical ureteric reflux, which is one of the commonest cause of urinary tract infection. And the three imaging modalities, that is the ultrasound, MCU, and DMSA, are the commonly used techniques to assess the structural and functional integrity of the urinary tract. Previous guidelines recommend aggressive imaging following the first episode of UTI. So let's have a quick look what does the previous guideline tell us. So after the first urinary tract infection, if the child is less than 1 year, then we do an ultrasound, MCU, as well as a DMSA scan. If the child is between 1 to 5 years, then the child is subjected to both ultrasound and a DMSA scan. And if either of one is abnormal, then we proceed with an MCU. If the child is more than 5 years, then we go ahead with an ultrasound. And if that is abnormal, then an MCU and a DMSA scan is done. And a child with recurrent UTI, all the three imaging modalities are done. So this is the previous guideline, and let's see what has changed. Now the rationale behind this aggressive imaging in UTI has been questioned for several reasons. Why? Because MCU is the modality of choice for diagnosing VUR, and it is definitely painful. You have a painful catheterization as well as radiation exposure. And if all children who have a UTI, if they undergo an MCU, then VUR is diagnosed in only 1/3 of these children. And above all, even after the diagnosis of a VUR, no intervention has proven beneficial in preventing the end-stage kidney disease associated with this vesicular ureteric reflux. But we all know that uroprophylaxis or a surgical correction helps in preventing the recurrences. So considering these balances, the recent guidelines emphasize less aggressive imaging following the urinary tract infection. So coming on to the new guidelines. So after the first episode of UTI, all children, they undergo an ultrasound. And if the ultrasound is normal, just follow them up. If the ultrasound is abnormal, then they are subjected to an MCU. And if there is a high-grade reflux, then a DMSA is done after 4 to 6 months. Or if a child has a non-E. coli UTI in less than 2 years of age, then we go ahead with an ultrasound, MCU, and DMSA only if there is a high-grade VUR. But if the child has a recurrent UTI, just like the previous guideline, here also we subject them to all the three modalities, that's the ultrasound, MCU, and the DMSA. So we'll go through some cases and let's see how we are going to manage them based on the current guideline. So here's a 3-year-old girl who presented with fever for 3 days. On examination, she had renal angle tenderness, Investigations showed polymorpholeukocytosis, a very high CRP. The urine analysis shows plenty of pus cells, nitrites and leukocyte esterase are positive. The culture shows E. coli 10 power 5 colony-forming units in a midstream clean catch. So Dr. Alpana, what do you think is the diagnosis and what investigations would you consider next based on the guideline? Mic is not on.
The diagnosis is acute pyelonephritis, and obviously the first investigation to do is ultrasonography of KUV. With regards to the timing of ultrasound, there has been a little change with regards to the timing of ultrasound following an episode of acute pyelonephritis. Now previously, ISPN 2011 guidelines mentioned that USG must be done soon after diagnosis of UTI, and this was the same recommendation for all children with UTI. There was no differentiation. Now the ISPN 23 guidelines mentions that the timing of sonography can be any time following the episode of UTI. However, it does recognize that there are a few children who require it early. That is, early USG is required within 48 hours of antibiotics if the child do not show clinical improvement in 48 hours or there are features of obstruction of lower urinary tract. So such children may be developing renal or perirenal abscess or pyelonephrosis. So that is why they require early sonography. For the rest of them, it can be done at any time. Now why this differentiation? Because it has been recognized that E. coli endotoxin per se can cause dilatation during acute infection of the tract, which can simulate hydronephrosis and pyelonephrosis, and even the edema of pyelonephritis can cause changes in the kidney size, shape and echogenicity. So if it is done very early on in all the cases of UTI, we may be over-diagnosing hydronephrosis, pyelonephrosis, and sonography as a marker of renal growth for monitoring, etc. may not be truly representative. So the differentiation into two groups.
I mean, you don't worry about the dilatation part. Acute UTI will not result in much of dilatation. So that is not the entire reason. But then it's only urgency is only there when it's you suspect a urosepsis or you suspect a posterior urethral valve or a complex anatomical abnormality. Otherwise, you can do it at ease at about 4 weeks, 6 weeks.
So, Dr. Jitendra, can you tell us what an optimal ultrasound is in a urinary tract infection child? So, what are the things that we need to look into in an ultrasound?
So, already being discussed, an ultrasound is important investigation when we are evaluating kids following a febrile UTI. And as most of you are aware, it's an operator-dependent modality. So first we need to be sure that who is ever doing ultrasound, especially in younger kids, does have some expertise, because it's not easy to handle younger kids for doing ultrasound. So one would want to have detailed evaluation of kidney, ureter, as well as lower tract, including bladder and if feasible urethra. So one would look at the assessment of bladder, which should ideally be look at the post-voyage residue, bladder wall thickness, and there might be internal content within the bladder wall contents, which may be debris or maybe a stone or hemorrhage. Then ideally a good ultrasonologist should be commenting on ureters as well, whether they are dilated or there is ectopic insertion, which might not be feasible at every time, and then look at the assessing the surrounding structure. Then coming to the upper tract, a good ultrasonologist should also be commenting on the location, orientation of kidneys, whether they are well rotated or they are at ectopic side. Kidney size and shape does give an importance when we are evaluating for febrile UTI, because if there is a discrepancy in kidney size, one kidney might be hypodysplasia, or there is other way around, that kidney might be enlarged in a patient with pyelonephrosis. So that does give you a clue of underlying, congenital anomalies. So other important thing is dilatation of pelvic calyceal system. I'm sure that later on they will talk on antenatal hydronephrosis, so then it will be discussed in detail. But if there is dilated pelvic calyceal system, it does give you clue of underlying congenital anomalies. So that's one of purpose of performing ultrasound, that we are looking for clue whether there is underlying congenital anomalies. So some of the clues where we would consider ultrasound to be abnormal, that if you have hydronephrosis, which is anterior posterior diameter of more than 7 or maybe more than 10, if there is a dilatation of ureter, kidney size discrepancy of more than, typically we consider as more than 1 centimeter difference, if there is a double collecting system. And if you have bladder wall thickness or increased PVR, it does suggest of underlying bladder wall dysfunction or maybe some other obstruction in downstream in urethra.
Thank you, Jitendra. As you said, it's a blessing in disguise to have a good pediatric radiologist with us, because our entire evaluation would be based on a very good ultrasound. And if you have any doubts, please discuss with your radiologist and then proceed. So now this child, who is 3 years, the right kidney is 8.6 centimeters. It shows increased echogenicity with a mild dilatation of pelvic calyceal system and ureter with pelvic wall thickening. The left kidney is 7.5 centimeters, normal CMP PCS, it's normal, and the bladder is also normal. So Dr. Jitendra, what do you think would be the next imaging looking at this ultrasound, and what would be the indication and timing of the next imaging?
So again highlighting that a good ultrasound is important, because that does determine our further evaluation. And if you have misreading of ultrasound, it might lead to unnecessary radiation exposure and further imaging. So I've seen in this ultrasound report of this patient that there seems to be discrepancy of kidney size in right and left kidney, almost 1.1 centimeter. And right kidney does show some dilatation of pelvic calyceal system. Ideally, good ultrasound report should have mentioned the anterior posterior diameter in this setting. So as there is, this patient did have febrile UTI, and the initial imaging of ultrasound of kidney, ureter and bladder is showing some clues that there might be underlying congenital anomalies. So next imaging modality would be micturating cystourethrogram, because one of the important risk factor for febrile UTI is primary vesicular reflux. Almost 1/3 of kids who initially present with febrile UTI may have underlying primary vesicular reflux. So in previous guideline, all infants with first UTI used to have that's what they recommended, that we should need to do MCU in every kid and below 5 years of age. But now it have changed. So we are bit more restrictive in our approach in terms of imaging. This chiefly highlighted already that even if we detect low grade BUR, we don't have anything, any intervention to prevent the long-term kidney damage or even like recurrent UTI, because I'm sure Professor Hari would be discussing in the next talk about antibiotic prophylaxis role in low grade BUR. So we don't have anything to change, in low grade BUR. So why to unnecessarily detect that thing which we can't change? So we are now a bit more restrictive in an approach of where do we should perform micturating cystourethrogram. So definitely there is no doubt that if you have abnormal ultrasonography, one would need to look at the detailed anatomy of urinary tract by micturating cystourethrogram, because that's the gold standard which we have for primary vesicular reflux detection. The other indications are there have been recently, at least for over last 1 decade, that there is some indication that if you have UTI secondary to non-E. coli. E. coli is the most common organism which lead to urinary tract infection in kids. But if you have uropathogen which is non-E. coli organism, the probability of detecting high-grade BUR is high. So that's where we, formulated this one of the clinical practice point, that if you are finding the non-E. coli UTI is uropathogen, one would need to look at the MCU. The third indication is that you have recurrent episodes of UTI, then the probability of detecting high-grade VUR is high. So these are three indications currently which we have, for going ahead with micturating cystoid program.
So what do you think is the timing of MCU?
So in terms of timing, as such, there is no data to suggest precise timelines, but it can be done any time after once you are I think lesion, you are happy that you have treated the kid, she has improved illegally after completion of antibiotic therapy, you can do it any time. But obviously you would not want to wait for 6 months or 1 year. It's any time, probably maybe within 1 month or 2 months after completing, even earlier. But obviously you would not wait for 6 months or 1 year. So
I think around 1 month would be ideal, but if you have no choice and you have to do it, then once you treat the UTI completely, then you can go ahead.
Sometimes parents are also anxious that they want to detect whether there is anything abnormal underlying VOR. They would want to do it as early as possible. So there is no contraindication of doing it after completing antibiotic therapy.
So Dr. Subal, do you think there's any precautions that needs to be taken while doing an MCU, and what are the pros and cons of the MCU?
So there are other modalities to detect reflux in children. However, the micturating cystoid is the gold standard to not only diagnose, also staging of reflux. Also, we can get a real X-ray of the lower tract during voiding. Besides, we can delineate the anatomy of the lower tract, and we can detect if there is presence of any obstructions or evacuation like Western wall. In the other side, it is an invasive procedures. We need to put a catheter in the bladder. Also, it causes discomfort to the child as well as anxiety to the parents. And also, we are talking about the exposure to radiations. Therefore, the current guideline is more of a restrictive approach, rather doing all the children having UTI. And regarding precautions, as I have told, there is risk of infections because you are putting catheter, so there is chance of introducing very little bacteria into the bladder. So, strict aseptic precautions should be taken during the procedures. Some centers they use the antibiotic prophylaxis, very procedures, starting from one of the procedure, during the procedures and after the procedure, 3 days antibiotic prophylaxis. But again, it's very from central centers and there is no strong evidence about it. And regarding radiation exposure, you need to follow the guidelines, you need to follow restrictive approach and need to minimize the radiation.
So I think with our scenario, it is very important that we take aseptic precautions, and if required, many times it might be very difficult. So we'll go ahead and give a prophylaxis if required. Dr. Atma, can you quickly tell us how to read an MCU?
We first have to understand what MCU basically is. MCU is use of series of X-rays and radio contrast to see real-time images of the lower urinary tract for anatomical assessment and functional assessment of the bladder, urethra and diagnosis of VUR. So fluoroscopy, when the person who is doing the MCU, he has the advantage of seeing the whole urinary tract real time. So and can judge the capacity and even decide when the VUR started, and he can also time when the spot images should be taken. What is available to the nephrologists are actually the spot images which have been shot, and on the basis of which we read the MCU and diagnose the VUR and grade it. Now, the number of spot images has undergone a change. Previously, a scout image and number of voiding images, etc. were taken. Now, the consensus is to have at least 3 spot images, and that is 1 in the filling phase, 1 in the voiding phase, and 1 post-void. We have gone away from routine scout image. What is important is the filling and voiding and post-void. In girls, it's all AP projection, whereas in males, you have to take a lateral or anterior oblique projection during the voiding to be able to visualize the urethra very well and diagnose PUE. So when we are reading these images, again we go according to the filling phase, voiding phase and the post-void. The filling phase gives very good information about the bladder capacity, presence or not of any trabeculations, and even some bladder neck visualization is possible. Sometimes we can even see VUR during the filling phase. It's a low pressure reflux. The voiding phase is actually the best to visualize the VUR. It is important that when this image is taken, the whole of the kidney, ureter, bladder, urethra, whole of it is visible. If you don't shoot a big image, you may miss this. And plus, the voiding is obviously the best image to see the urethra, the caliber, the dilatation, presence or not of VUR. The post-void image is to see, again it's an indirect marker of reflux, if there is any residue or not. Coming to the grading of reflux, because a lot depends upon not only the presence or not of VUR but also the grade. It's graded from 1 to 5 in increasing order of severity. Grade 1, there is only opacification of the ureter. Grade 2 is opacification of the ureter, pelvis and calyces. Grade 3, besides opacification, there is dilatation of all this, but the pharyngeal angle of the calyces is maintained in most of the calyces. In grade 4, this besides the whole of the ureter becomes really tortuous and pharyngeal angle is obliterated in most, but papillary impression is retained. And grade 5 is when it's even the papillary impression on the calyces is totally lost. Calyces are all blunted and obliterated, and there's a lot of dilatation and tortuosity of the ureter.
So going back to the case, we have done an MCU because the ultrasound was abnormal. The MCU shows left grade 2 and right grade 3 VUR.
Right. So this is because on the right side, all the calyceal fornices are visible. That is why the differentiation between 3 and 4 is possible if we look at the calyces and the fornices.
So Dr. Jitendran, having known that we are having a high grade reflux, what would be the next investigation of choice, and what would be the indication and timing and the pros and cons of the next investigation?
So this kid had already an episode of febrile UTI, and on MCU is showing high grade VUR. So next step is to assess, because VUR can associate with kidney scarring, and already there is episode of febrile UTI. So we would want to look at whether there is any kidney damage in terms of kidney scarring. So that gold standard for kidney scarring with current scenario is late phase DMSA scan. So late phase DMSA scan, what I mean is 4 to 6 months after an episode of febrile UTI. So there is a lot of debate whether we should be doing acute phase DMSA scan or not. While acute phase DMSA scan is probably gold standard for diagnosing acute pyelonephritis, but there are issues when it comes to detecting the kidney scarring. Acute phase DMSA scan doesn't differentiate between acute pyelonephritic uptake defect and the permanent kidney scarring. So it doesn't help in detecting the permanent scarring. Second thing was top-down approach, which used to be one approach, but it doesn't help in detecting the high-grade VUR. So the sensitivity and specificity is pretty much poor with the acute phase DMS scan in predicting the high-grade VUR. So in current guideline, we are clearly recommended that we don't need to do acute phase DMSA scan. So that's one of the major change which we have come with in ISPN guideline in 2023. That there is no indication of doing acute phase DMSA scan and unnecessary exposing the patients to radiation. You can go back to previous slide, please. So the currently indication for late phase DMSA scan that the patients have high grade VUR, because there you have high probability of detecting kidney scarring, and the second one is recurrent UTI. So repeatedly I am sure that we are mentioning two things, that we are focusing more on high grade VUR because we don't have anything, even if we detect kidney scarring, we don't have anything to change that. Or neither there is intervention to change long-term outcome. So we are trying to be as restrictive as possible in terms of radiation exposure and unnecessary stressing kids with the unnecessary imaging modalities.
So we all understand that we have to do a late phase DMSA, and even the indications are quite less. Now this is going back to that case. This child has right kidney scarring in the upper pole and its function is 42%. The left kidney there are no scars and 58%. The child was initiated on uroprophylaxis for 1 year and then stopped. Child was counseled for regular bowel and bladder habits. There was no breakthrough urinary tract infection in this child. Dr. Subal, what are the indications and timing of a repeat ultrasound during follow-up? So when we follow up such high-grade reflux children, how are we going to repeat the ultrasound?
So this is a child who had bilateral reflux and right side had grade 4 reflux, having reflux and nephropathy. Therefore, she's having risks of long-term morbidity, including proteinuria, hypertension, growth. So therefore, need to monitor on follow-up. At least need to do a renal ultrasound annually to look for the growth of the kidney size versus the growth. Without any high-grade reflux, maybe you were less frequently those having high-grade reflux.
So the main aim for us to repeat an ultrasound is to see the interval growth of the kidneys are good, and if it's a high-grade reflux, then it's at least done annually and less frequently if the child is asymptomatic or older. Now in this child at 4 years, you could see that the interval growth is quite good with a mild BCS dilatation and ureter. And when the child is 7 years also, you could see that the growth of the kidney is quite good, but there is subtle prominence of the BCS and ureter. Now, the parents, they are quite anxious. They want to know if a repeat DMSA is required to look for the resolution of scars. So, Dr. Subal, what do you think would be the indication for a repeat DMSA, and do you think it is indicated in this child? So, this child has been doing well, there is no breakthrough infection, and this child is just under follow-up.
So, as per the current guide, there are very specific indications about DMSA because it involves the cost, radiations, and many centers it is not actually available. It is required only in case of recurrent UTI to look for any apex of new scar or any deterioration of previous scar. So in particular, this child is doing well and then no further UTI or prophylaxis. Therefore, not required further follow-up with the DMSA scan.
So this child has no breakthrough UTI, and so we are not going to do a DMSA. We have explained the parents the same, the risk of radiation and cost, and they are convinced. But now, as parents, they would know if when they should repeat the MCU to look for the resolution of reflux. So Dr. Alpana, can you tell us what would be the indications and timing of a repeat MCU in these children?
Now, what the ISPN 23 guideline says, that repeat MCU just for the documentation of resolution of VUR is not required in each and every case. However, if the caregivers or the persons who are delivering the care they deem it necessary to do it, they may do it 4 to 8 years following the initial diagnosis. Now, this is based on the assumption that evidence, not assumption, but the evidence, which shows that most primary VURs show spontaneous resolution, and the timing they take to resolve, it varies from 4 to 8 years. The higher grades take longer, the lower grades show resolution faster, roughly 70, 60, 50 for grade 1, 2, 3, and 30% for grade 4, grade 5. This is the rate of resolution of VUR in normal course of circumstances.
So we do understand now that MCU is always not indicated during follow-up, but if deemed necessary by the treating physician or if the parents request for one, then we repeat it. Now this child is 9 years old and has done really well without any breakthrough urinary tract infection. But still the parents want to know if the VUR has resolved. But at the same time they are worried that MCU would be painful. So Jitendra, can you advise an alternative investigation for MCU in this child, and what would be the pros and cons?
So MCU has been discussed already. It's a gold standard, but I'm sure most of you are aware that there is a small proportion of VUR which can be missed on MCU. So there is alternate modality which is radionuclide cystography. Radionuclide cystography as such more sensitive than MCU, but the problem with DRCG that you can't have anatomical delineation with the as good as with MCU. And overall, if you are doing it with intravenous route, you can avoid catheterization as well. But problem with that, obviously you can't have detailed delineation of anatomy. Radiation exposure is probably lesser with DRCG compared to MCU. So if parents are pretty much anxious and they are repeatedly insisting, one can do DRCG to look for resolution of viewer. But obviously you won't be able to compare the grade or downgrading of viewer with DRCG.
So DRCG can be used as a modality to follow up the reflux, and it cannot be done as the first line of diagnosis of a reflux because the anatomical details will not be outlined. So that's very important. And in this child, the repeat DRCG showed resolution of reflux and child is well. So going on to our next patient, here's a 1-year-old girl who presents with fever for 4 days associated with cry during micturition. Again, all the pointers are towards UTI, and the ultrasound shows a left kidney of 6.9 centimeters with mild dilatation of PCS, and the AP diameter is 1.4 centimeters with normal echogenicity. The right kidney is normal. So this is the MCU of this child, which shows a grade 4 VUR on the left. We have gone ahead and done an MCU because the ultrasound was abnormal. And the DMSA, which was done after 4 months, shows scarring in the upper pole of the left kidney with 45% function. She is on regular uroprophylaxis and has had breakthrough urinary tract infections in the last 15 months. Dr. Alpana, what do you think would be the next imaging in this child and management plan?
Since the child has had breakthrough UTIs, we would require a repeat DMSA to show if any further scarring has happened. And because she is still having UTI on a continuous antibiotic prophylaxis, she's a candidate for intervention. So surgery is what she requires for reimplantation.
Recurrent breakthrough UTI should be febrile UTIs, not just cystitis. So in that situation, if your antibiotic prophylaxis is not working, then in those situations you can consider doing either surgical reimplantation or endoscopy, injection of a bulking agent.
So now in this child, because of a high-grade VUR with recurrent febrile UTI, despite being on prophylaxis, this child underwent left ureteric reimplantation. Child is on regular follow-up and is doing well. Now coming on to our next child, here's an 11-month-old girl who presented with fever for 3 days associated with vomiting and cry during micturition, and again all the investigations points towards UTI. The urine culture showed E. coli 10 power 5 coliform units, which was significant. The ultrasound of this child shows a right kidney of 5.9 centimeter, left kidney of 6 centimeters, bilateral normal echogenicity, no pelvic calcium system dilatation, the bladder is normal, so almost the ultrasound seems to be normal. Dr. Subal, what do you think would be the next imaging? Would you consider doing the next imaging as the child is 11 months and definitely has a febrile UTI?
So, as per the current guideline, only one episode of febrile UTI, again that is E. coli, and essentially normal ultrasonography doesn't require further evaluations by MCUG or DMSA. But US guideline recommended any child having febrile UTI less than 1 year, you got all the 3 modality of investigation: ultrasonography, MCU, and PCUG. So as of now, the current guideline, if ultrasound is normal and doesn't require further evaluations, however, need to follow this child. Any further episodic features, then may need further investigations.
So as Dr. Subal said, this being a 11-month-old child also, because of a normal ultrasound, we are not going to proceed with any further investigation. But let's look what happened before, because this was done based on the previous guideline. We had gone and done an MCU, which shows almost a grade 2 VUR on the right. The DMSA was done quite immediately, and we could see there was a small area of inflammation in both the cortices, and the repeat DMSA did not show any scars. The ultrasound did show a good interval growth of the kidneys, and MCU, which was repeated at 7 years, showed no VUR. So what do we understand from this child? A child who has a low-grade BUR has a high chances of resolution on its own, and if we are going to do all the investigations, we are going to subject them to unnecessary radiation exposure and trauma. So as per new guidelines, this child needs no further evaluation as ultrasound has no major abnormalities. But do remember that you need to follow up these children very carefully, because it's always not as rosy as we think it is. So it is very important that we follow up these children. Coming to our last patient, here's a 13-year-old female who presented to the outpatient department with lower urinary tract symptoms and recurrent UTI. She has habitual constipation, does not void urine in school. And so, Dr. Alpana, what do you think would be the imaging that you will do in a child with recurrent UTI?
So this girl has all the features of bladder bowel dysfunction. So she warrants a complete anatomical and functional evaluation of her lower urinary tract, which means that she needs sonography, she needs MCU, and she also needs a DMSA.
So as far as the recurrent UTI, the older guidelines and newer guidelines fall in the same line. So we need to do all the three imaging modalities. This child's ultrasound shows right kidney of 10.1 centimeter, left kidney of 10.8 centimeters normal echogenicity. The bladder wall shows thickening, and there was a significant post-void residue of 40 ml and loaded rectum. And the impression that the radiologist has given us is cystitis. Dr. Jitendra, what do you think is the abnormality in the above ultrasound, and what is your thought on the final impression being cystitis, which is commonly reported?
So in terms of abnormality, already enumerated, there is a thickening of urinary bladder. So it might be suggesting that there is voiding dysfunction, whether it's obstruction or bladder bowel dysfunction. But her fecal rectum is also loaded, so it suggests more of constipation and combination of bladder and bowel dysfunction. So these are cutoffs where that you have post-void residue of more than 20 ml for 4 to 6 years, or in terms of percentage more than 10% of normal voiding capacity, and is slightly less for more than 7 years. And you have bladder bowel thickening with fecal loading in rectum. All these are suggestive of there is a bladder bowel dysfunction, and which is again one of the important risk factor for recurrent UTI, which sometimes we tend to miss or forget about treatment. It's probably as important as vesico-ureteric reflux in terms of risk of developing febrile UTI. The issue about this ultrasonologist did make diagnosis of cystitis based on ultrasound finding, which should not be done absolutely big no for diagnosing cystitis based on ultrasound. The diagnosis of cystitis should be based on urine culture and symptoms. Ultrasound has absolutely no role in diagnosing the lower urinary tract infection. It should be based on the documentation of organism on urine culture. So even in my institute, I do get multiple times this ultrasound saying cystitis. You don't need to treat it unless your urine culture is showing organism.
So as you rightly pointed out, most of the time cystitis, the BBD is wrongly reported as cystitis many times. So be very careful, because it's one of the commonest cause for recurrent UTI. If not treated, then we will be in trouble. So this is the DMSA of this child, which shows left kidney of 50% was slightly enlarged, and the right kidney, which also had 50% function, but had multiple photopenic areas in the upper poles. The MCU also showed spinning top deformities, so all these are pointing towards the bowel bladder dysfunction. So this child was treated with appropriate advice. It was on regular follow-up with no breakthrough infections for the last 1 year. Dr. Subal, finally, can you enlighten us? What do you think is the role of imaging to screen siblings with vesico-ureteric reflux?
So again, this is a debatable topic, but as per the current guideline, the recommended screening of all the siblings less than 3 years of age with the ultrasonography. However, there is no strong evidence to back the data, the recommendations, but it has been found that about the high grade reflux is noted in 20 to 60% in sibling with primary fever. So if the sibling less than 3 years, younger than 3 years, then need to do ultrasonography. However, if any symptomatic UTI, they need to follow as part of protocols.
So we come to the end of the session, and I would summarize whatever my panelist has taken us so far. The ultrasound should be done anytime after the first episode of urinary tract infection. MCU should be done anytime after completion of UTI treatment in children with non-E. coli UTI in child less than 2 years of age, those with an abnormal ultrasound, recurrent urinary tract infection, DMSA to be performed 4 to 6 months after UTI in children with high-grade BUR, ultrasound, MCU and DMSA, all the 3 investigations to be done in children with recurrent UTI. Follow-up, the ultrasound is performed periodically to monitor the renal growth in children with high-grade vesicular reflux. DMSA is to be repeated only in children with recurrence of UTI. MCU may be repeated after 4 to 8 years following the initial diagnosis if deemed necessary by the treating physician. DRCT is an alternative for repeat MCU to check for reflux resolution. And finally, we need to understand guidelines are to guide management, but treatment has to be individualized, and it is the primary care pediatrician's share to appropriately diagnose and manage UTI. Thank you.
Thank you, panelists, most of all for finishing in time, both the lecture and the panel discussion. And now I open this forum for the audience. You have a rare array of experts to answer all your questions on day-to-day clinical practice on UTI. You can allow a few questions. So, and I would like to invite Dr. Abhijit Shah to come on the dais. He can also share this dais and take part in. Is it there? Okay. So, if there are any questions or comments, yes.
and very rapidly the bacteria disappears, and at the same time also when the WBC count, if you clinically based on the history and if there are any urine microscopy, you can figure out, then at least give at least 7 days of treatment. And I would then say if you have a doubtful UTI, do not subject him to any investigation, and you can easily wait for another UTI. But do tell them that if the symptoms occur, do not start antibiotics, do first urine culture and microscopy.
Can I come across? So once again, madam, your very valid question. This is where a radiologist can help us. So if we have an astute pediatric radiologist, they can really identify a hypoechoic ecotexture of the inflamed kidney secondary to UTI. If you have a setting of high CRPs, and they come across and tell us, I think this is an inflamed kidney. You're not looking at anywhere else. It's just like you look at hyperechoic ecotexture of the liver when it is hepatitis. So the hypoechoic ecotexture of the kidney to an astute radiologist. I mean, I'm lucky to have it in my center, being at exclusive pediatric children's hospital Rainbow in Bangalore, where our pediatric radiologist has organized her thoughts to only look at these tough situations which we face across. So that's where something we have got an advantage to look at. Point number 2 was looking at the interpretation of MCU. Now MCU, when we ask many times from our colleagues in radiology or if our pediatric surgeons are helping, it is very important that we identify and ask them to write what was the filling volume at which they fill the bladder. Many a times it's a small child crying, parents cannot take it, the child has just ejected the urine, and it was say a 2-year-old child and the child has thrown the urine at 50 ml. And then they will put a list, no reflux detected, but they forget to mention what was the filling volume which they attempted. And that is something which brings completion to the report. And if we as clinicians, pediatric nephrology or general pediatricians get behind our radiology colleague, they do it and they start writing the filling volume, or they mention that 75 ml taken in 2-year-old child, which is incomplete filling volume, and an MCU cannot be ruled out. And that something comes over a period of time. But I think it should be retrograde from our side to the radiologist.
So
what's your take on this, Dr. Hari sir?
Yeah, so response to your first comment, I don't agree. I mean, you may have a radiologist, but you don't need to make a diagnosis of UTI by ultrasound. You should give the message that it has to be urine culture.
Clinical sense, sir, it drives us to there because we are seeing an inflamed
patient. I mean, I would not tell him that you will get an ultrasound done if your culture, because your culture is now sterile, and I want.
No, it's not about sterile, sir. It's like within 40 to 72 hours. If we are planning, if we are blind, if the cultures are not supporting us.
Abnormalities on the ultrasound are not really well tested in terms of sensitivity and specificity. So I mean, a lot of things when we said that an abnormal ultrasound, the chances of picking up fewer, but you know, there's one abnormality or there are multiple abnormalities, the sensitivity and specificity will vary. So that's why we don't come out as a recommendation.
No, I'm not talking. What madam's question was in a situation, sir, where the patients have received the antibiotics. So this is not a very ideal and a practical situation, but where there is a small modality which can pick up. It's just like brain.
Yeah,
many times we have encephalitis.
Would be that you just complete the treatment, wait for the next UTI, be very careful. The second point is very well valid, that if you have not given enough contrast and have not filled the bladder, you very rightly said you might miss a week.
So I was mentioning after the person who's doing the MCU has, it's much more than what we get on the patient. So we must insist that they share the information of how much they had to instill and at what volume the reflux happened. Because filling reflux is that the voiding reflux, even the implications are different. The time of resolution, the likelihood of resolution is different.
Thank you. Thank you. The all managers are looking at us. Yeah. Yeah. Sir, your question, please.
Thank you. It was a very nice and clear session and didactically well done. I have a comment to the discovery or search for VUR. So the pendulum in the interpretation swings from extreme from one side to the other over the last decade or 2 decades. Now, VUR, as we know, is actually in most cases an anatomical variety. It's not a disease. We have to remember that. So whether we detect a second degree or third degree reflux or not has actually no bearing
for the long-term outcome of the kidney health. What we need to know is whether a boy has PUD. We need to know whether there is a major abnormality of the urinary tract, one or the other kidney. That we have to figure out. So in most cases, I would not even chase with MCU whether there is a reflux or not, unless I see already by ultrasound there's something majorly wrong or we have a high creatinine. And that shifts slightly the expectation also of the parents to have to know whether the VUR has resolved or not. If there's no more high number of infections, it doesn't really have any importance. So I just wanted to emphasize or re-emphasize that.
Absolutely correct. I agree with you. And in fact, three things: UTI, VUR, and the scarring. They've been connected together, but they seem not to be related. And I always call VUR an innocent bystander. You know, it's been implicated that this is the one that caused the renal scars or damage or ESRD. It actually is not. It's just associated lying there, and so one needs to understand this. And doing research over this condition for last 20 years, I do understand now there are three different conditions, but they seem to just coexist.
And just to re-emphasize that scars are in most cases innocent as well. And they are 50% already at birth. And there's no difference whether you prevent infection or not, how many scars you develop. And they're very rarely associated with hypertension. That was our big concern in the past. So whether we know that or not is usually not relevant.
Thank you, sir. And I think we should conclude here. And I would ask Pankaj sir to give us just a few short and crisp concluding remarks.
I will talk subsequently, so I would rather like to take a little longer, maybe a minute or so.
Thank you. And I know doubts will be there, and experts will be there with us. We can discuss outside the hall and maybe during lunch hours. Thank you.
Thank you so much all of you for such an indeed and useful session for all of us. Becoming more clearer for as we are spending more time with all of you. So for the next session, I would like to
his opinion on prophylaxis, antibiotic prophylaxis, UTI, which we know is a very controversial topic. Thank you, please.
Thank you, sir. So it's a great privilege to be talking to you all on the role of antibiotic prophylaxis in UTI, and more so since we were involved in developing a very evidence-based guideline for last almost 3 years, maybe 3.5 years, and the guidelines are now been published, and they will be soon available. And we also intend to write a very brief summary for Indian pediatrics, so that, you know, for practitioners, if they're not able to read those 34 pages guideline, it will be difficult. So in my talk, I'm going to tell you about what we figured out while we were doing we were formulating the guidelines based on the evidence and also on various other parameters. And I'm thankful to the whole guideline panel of about 30 odd people who put in all their efforts in formulating the guidelines. So we'll be telling you about what is the role of antibiotic prophylaxis if you have a normal urinary tract, if you have a bladder bowel dysfunction, if there is a primary vesicoureteric reflux, and I'll not be talking about the secondary form of VUR, which is neurogenic bladder and posterior urethral valve. What is the role of antibiotic prophylaxis in antenatal hydronephrosis, and also now since there's been an interest in what is the role of antibiotic prophylaxis in antenatally detected VUR, where the UTI hasn't happened, and unfortunately we have this large randomized controlled trial which is on for last almost 8 years, and the results are very recently published only last month. So I'll share some of the results from that from the NEJM paper. So what is antibiotic prophylaxis? I think we don't even remember the origin of this intervention. How was it conceived? In fact, must be in 60s and 70s. You know, when people were treating UTIs, and UTI was supposed to be more like a chronic infection, that it was difficult to eradicate this infection from the renal parenchyma. And that's why if you look at the literature in 60s and 70s, they would be treating this infection for a prolonged period with antibiotic therapy for maybe 3 months, 4 months, and gradually they then decided that in order to sort of eradicate the bacteria or not let the recurrence happen, why not give smaller doses of this antibiotic for a much longer period. So that's how this kind of intervention evolved, that you give a small dose of an antibiotic, a therapeutic, almost like 1/4 to 1/5 of the therapeutic dose, and given over a period of 6 months, or 8 months, or maybe a year to prevent recurrent infection. Or in those days, people used to think that it is the bacteria which is hiding in the parenchyma and so as to eradicate it. But we now know that the infections are not chronic. Previously, it used to be called as chronic pyelonephritis. And you know, the name has changed now. We know that those damaged kidneys are not, in fact, chronic pyelonephritis. They are associated with VUR, and they are nowadays called as reflux nephropathy. But there is another objection to this term, because it is not actually caused by reflux of the sterile urine. It is actually a congenital dysplasia. So the terminology still stays as reflux nephropathy, but it might change in future. What is the mechanism as to how these antibiotic prophylaxis work? Nobody knows clearly, but perhaps by decreasing the periurethral colonization and maybe changing the gut flora. And there is some evidence that the intracellular bacterial communities in the bladder may be reduced. So what they say, that the bacteria enters the cell and it hides, and then after some time, after 3 weeks or 4 weeks, see the same E. coli comes out of the bladder and then causes the UTI. So these are the postulated mechanisms. One doesn't know exactly how it works. But these are the drugs, and cotrimoxazole, nitrofurantoin, cephalexin, cephadroxil, and amoxicillin. But the first two are the ones which have been widely studied and tested, and that's why the guidelines suggest that one should use, if you have to choose cotrimoxazole or nitrofurantoin as the first line antibiotic therapy prophylaxis in children who are older than 6 months. There is some concern about using trimethoprim in first 6 months, and that's on also in G6PD deficiency, and therefore you can then use cephalexin or amoxicillin. So while we were formulating the guidelines, a lot of changes have happened, and we all know when we talk about any intervention, we look at and everybody knows that we look at the balance between the benefit and harm. But there are at least another 4 domains that are important when you formulate or you say that I recommend using this intervention. And the other 4 are importantly certainty of evidence. Now I'll deliberate a little bit more on this, and also whether it is feasible, available, and what about the equity, and also the values and preferences. So I'll not go into details of the others, but we know that antibiotic prophylaxis is not expensive, easily available, so those are not issues. If you look at the benefit and harm, then based on the trials, now we know that the benefit is very marginal with antibiotic prophylaxis. There is none if you have normal tract. There is marginal in high-grade VUR. And if you look at the renal scarring, there is no benefit whichever trial you look at. If you look at the harm, there is significant antimicrobial resistance that happens. And that is why the whole balance has shifted. There is more harm than benefit. Now if you look at why certainty of evidence is important, certainty of evidence means that what is the quality of the evidence, how good are the studies, how robust is the effect size or the evidence or the benefit, etc. So when we looked at the certainty of evidence for use of antibiotic prophylaxis, it was low. Most of the studies, there were problems, and so it was rated as low certainty of evidence for whatever benefit it was causing in prevention of UTI. On the other hand, if you look at this certainty of evidence for antimicrobial resistance, there was a moderate quality evidence, and that is why the whole balance is tilted. So we've used systematic reviews in the developing the guidelines, and so you will understand based on the systematic reviews that this is the line of no effect, and this is the diamond that tells you what it favors, whether it's favoring the intervention or no intervention. So if you look at the antibiotic prophylaxis, whether it is to be used in normal urinary tract, you can find that there is no difference really. So that's why, and the harm is there. So therefore, the guideline panel recommended against using prophylaxis for prevention of UTI in children with normal tract, and this is a strong recommendation. How about using prophylaxis in a child with bladder bowel dysfunction who has a UTI, since it's a very commonly associated condition? But if you look at the quality of evidence, it is a very low quality evidence. That's why we did not give it as a recommendation, but it's a suggested clinical guidance that you can consider in recurrent febrile UTI with bladder bowel dysfunction, and there may or may not be presence of a PUR. Now the whole issue of antibiotic prophylaxis usage, and since it was most commonly used for PUR, and that's why we'll look into as to how the evidence has changed. Now, PUR initially in 70s and 80s used to be treated surgically predominantly. They would also use continuous antibiotics in these patients and also give them surgery. Now what happened in those days in UK and other Western countries, that some of the patients didn't turn up for surgery and they continued to be on prophylaxis. And on evaluation and follow-up, they found that these patients were doing similarly as well as compared to these surgically treated patients. And that is what prompted people to at least consider, because antibiotic prophylaxis was taken for granted that this is a good treatment. And then they started comparing it with surgery. So that's how in 80s and 90s, there were at least 3 or 4 trials, large randomized controlled trials, that were carried out in UK and in Europe and in US, which compared antibiotic prophylaxis versus surgical reimplantation. In fact, it was both. It was combined treatment, you see, antibiotic prophylaxis plus surgery versus the antibiotic prophylaxis. And you could see based on this forest plot that there is no difference in all kind of UTIs. Also over a period of 4 to 5 years or 1 to 2 years. But if you just segregate the febrile UTIs, there is some benefit. You see, the diamond is shifted towards the combined treatment of surgery and antibiotic prophylaxis. So it only is helpful in preventing a febrile UTI. So that's why it was regarded that yes, based on this meta-analysis as good as surgery, and therefore by the turn of the century, this antibiotic prophylaxis became the standard of care for treatment of VUR, and surgery was left for very limited indications. Importantly, there was no difference in scarring at 5 and 10 years, whether you treat your patient surgically or you just put them on antibiotic prophylaxis. So as I said, antibiotic prophylaxis was taken as a standard treatment and taken for granted that, well, it works. It was only at this point of time in 2003 that people started questioning, well, we have not looked at this treatment against a placebo or no treatment. And this was very, very evident, because when in the All India Institute of Medical Sciences, our group and we wrote a grant to ICMR asking that I want to study whether this works against placebo, cotrimoxazole. And it was rejected, and they said, you are foolish, it's just a very standard treatment and this doesn't need a trial. At that same time, others also were looking at whether antibiotic prophylaxis was better than placebo or no treatment. And there was a French group, you may not be able to read them very well, but then there were trials going on in Italy, in France, also from Australia. This is the PREVENT study, which we all know. And finally, at the same time, we finally got the sanction, because after writing a rejoinder that, well, it is required to study, and so we got this funding for this trial, and we started in 2006, and it got published in 15 because of the slow accrual. And at the same time, you would already know that there's a large randomized controlled trial that came up from the US, which got published a little few months earlier than our study, and we had very startlingly different results. Now you could understand that's why we can discuss sometime later that why the results were so different. Look at our result. We showed that there was hardly any benefit. It's going on the other side. No treatment. This is placebo control. So it was towards placebo. In fact, UTIs were more in antibiotic prophylaxis group. Look at the benefit. Reward trial showed a benefit. Prevent showed a marginal benefit. The rest of the studies, again, they were just overlapping. Look at the confidence interval, they're all crossing the line of no effect. So when you combine them all together, you find that all RCTs combined, the meta-analysis shows that there's a very little benefit or maybe none in all kinds of VUR. This is all grade 1, 2, 3 and 4. 5 could never be studied because nobody would ethically allow us to study grade 5 VUR. So if you look at the low risk of bias studies, which means you've used a placebo and that those studies are very well done. So the AIM study, we showed that there was possible harm, more UTIs, prevent, failed to show any significant benefit if you segregated the VUR patients only, and RIVER showed a definite benefit. All combined, there was hardly any difference if you use low risk of bias studies. So based on this, it was questioned that whether should it be used in VUR. So what was done in the guideline when we were developing the guideline, we segregated the grades of VUR. So we said let's look at high grade VUR 3 and 4 versus grade 1 and 2. If you look at only high grade VUR, then you could see that both all the studies combined, there is a marginal benefit. The diamond is moving towards favoring the antibiotic prophylaxis. And this was the basis why we said, okay, fine, this is good in 3 and 4 grades of VUR. We look at renal scarring. It's not prevented by any of the studies except for the Swedish reflux trial, but it had a very wide confidence interval. The estimate is not good. And therefore, if you see the combined effect, the diamond sits right at the center, so there is no difference. So renal scarring is not prevented. On the other hand, look at the antibiotic resistance. All the studies that looked at the antibiotic resistance, they all showed the effect more against the antibiotic prophylaxis. That means there were more antimicrobial resistant isolates found in those studies where antibiotic prophylaxis was used versus no treatment or placebo. So clearly there was a harm, and this evidence was more robust as compared to the benefit. So there was another important question that should antibiotic prophylaxis be used in antenatal hydronephrosis, and we did not have good amount of data in terms of randomized controlled trial in antenatally diagnosed hydronephrosis. There were multiple studies all combined. You see there is no real benefit, but these are all observational studies also included, no randomized controlled trial. So this question was left unanswered, that whether we really know whether in antenatal hydronephrosis should use it. So so that's why the guideline panel suggested that we do not recommend use of prophylaxis or prevention of UTI in infants with antenatal hydronephrosis who are awaiting MCU. Once they are diagnosed to have a VUR on MCU, that's a different story. Now this was also a very relevant question, that even if they come out to be diagnosed as to have VUR, they have not had a UTI, whether they will develop a UTI in later life or not, and should they be given antibiotic prophylaxis. And this is the trial I was talking about, that's called the PREDICT trial, which began in 2013. And they were trying to look at whether antibiotic prophylaxis helps in preventing UTIs in antenatally detected VUR who have not had any previous UTI. So they took children between 1 to 4 months of age, high grade VUR, 3, 4 and 5 were included, because 5 was also now taken as that you can do trials in them. No history of previous UTI, and because it was about 20 centers in Europe, they decided that you can use various antibiotic prophylaxis because the practices were different in various centers. So they allowed nitrofurantoin, cotrimoxazole, coamoxiclav, vaccine. They intended to enroll about 400 odd patients, and they stratified them according to renal damage, and they were trying to look at the outcome at 24 months. Now the trial had very slow approval. They were fed up with the trial, it was not ending. Finally, it finished and got published in September, this last September. So they assessed 867 patients for eligibility, 575 got excluded because 201 did not have a VUR, they were antenatal hydronephrosis only. 189 already had a UTI, so they were also moved out. 154 were older than 5 months. So 292 randomized, 156 received antibiotic prophylaxis, 146 did not, 126 completed, 117 on this other group. There was some loss to follow. And if you look at this, the demographic profile, the key difference between the Indian patients and the US patients was that in the US, they were 90% girls. And they were worried, they wondered why VUR occurs in boys. But look at the European group, you can see that the number here is 77%, predominantly boys in again Europe. So that way maybe the US is looking at different set of population than the rest of the world. Look at the grade of VUR, they were predominantly high grade, and this was intended. And also a lot of patients, more than half of the patients had abnormality on the DMSS scan at the beginning. What was the result of this PREDICT study? At the end of 2 years, they did show there was a definite benefit in terms of that the untreated patient, 35% had a UTI recurrence, UTI episode. On the other hand, in prophylaxis, it was 21%. So there was a definite 14% benefit on using antibiotic prophylaxis. Time to first UTI was not different, and it didn't vary according to the antibiotic prophylaxis. But now see the difference. Now when the authors started discussing it, there was an interesting finding that said almost 2/3 did not develop a UTI. So why subject those patients also to antibiotic exposure, resulting in antimicrobial resistance? Because this study also found that antimicrobial resistance was higher. The isolates were chiefly non-E. coli, and while this hospitalization rate because of the occurrence of UTI was similar. So even if this was non-E. coli UTI, it did not result in more severe disease. And this is a very interesting finding, and this is hard to explain, or maybe I can explain because I've seen this happen. This is that almost 19% of children with UTI and 18% who did not have a UTI, they also had a new lesion appearing. Now one would say this is absurd, why a new lesion should appear if there is no UTI? But the reason here is perhaps we have seen some of these children, these are very young infants. You do DMSS scan in very young infants, sometimes smaller defects can't you may not pick them up, or actually the dysplasia also evolves with time. So those hypophotopenic areas will appear later, and they may be the new lesions. Because these patients are very regularly followed up for any occurrence of UTI. So you can't say that there was a subclinical UTI that was missed. And on subgroup analysis, they also found that females, so girls in fact benefited most, but not the boys, between in grade 4 and 5 VUR. So what the authors therefore suggested that maybe it is good to use it in females 4 and 5, but you can't draw this conclusion from a randomized controlled trial where this was not the primary objective, this was a secondary analysis. So this again has to be looked at, or if you are really interested in this. So overall the rate of scarring was similar, whether you treat with antibiotic prophylaxis, we do not. Importantly, 2/3 of the untreated patient did not develop any UTI. So we were worried that since this trial came later, we already had formulated the guidelines, whether our guidelines are going to be impacted, or should we be writing to the editor for an addendum. But we think that our guidelines are not affected by the results of the study. We had already suggested that prophylaxis may be given for prevention of febrile UTI only in children with high-grade primary VUR. And we also suggested that prophylaxis should be the first line of management in high-grade VUR over surgery. And we suggested only surgical implantation to be considered in high-grade VUR who have recurrent breakthrough UTI, which are febrile in nature, on prophylaxis. And we did leave this that the physician can decide that this is a clinical practice point, that if you have low-grade VUR in an infant, so the VUR is low-grade, but the child is an infant who has had a febrile UTI, maybe in that kind of situation, you can consider using antibiotic prophylaxis. About discontinuation, previously all antibiotic therapies or prophylaxis were given for at least 5 years till the child was 5 years of age. Now in this, we figured out from the studies that yes, antibiotic prophylaxis can be stopped in older children who are older than 2 years of age, are toilet trained, and there is no bladder bowel dysfunction, and they have not had a febrile UTI in the last 1 year. How are the different guidelines on prophylaxis, various other guidelines? Yeah, this is an old slide, so at that point of time we had taken even 2015 guidelines. But you look at the American Academy of Pediatrics, remains silent on antibiotic prophylaxis, doesn't talk about antibiotic prophylaxis. NICE guidance says give it in recurrent UTI.
The Italian guidelines, which were in 2019, they say yes, high-grade VUR, you can use antibiotic prophylaxis, similar to what Indian guidelines say. So what we say is high-grade VUR 3, 4, and 5, whether antenatal or after UTI, you can use antibiotic prophylaxis, and also in bladder bowel dysfunction, we suggest. So this is the algorithm, which is simply the same thing, low-grade VUR. If there is a UTI in an infant, you can still consider it, but otherwise use it for high-grade VUR 3, 4, 5. In the presence of bladder, and when can you stop? At least make sure that the child does not have a bladder bowel dysfunction, because otherwise there will be a certain recurrence of UTI, and the child should be toilet trained, no UTI in last 1 year, and we know the surgical indications are very limited, only if recurrent UTIs are happening, and this is failure of antibiotic therapy. So the final words, antibiotic prophylaxis is not indicated in normal tracts, also not indicated in those awaiting evaluation in antenatal hydronephrosis. It's indicated in high grades of VUR. Antenatally detected high-grade VUR also should be treated, and it can be considered in bladder bowel dysfunction where children are having UTI. And since there is a significant harm associated with the antibiotic prophylaxis, while it doesn't result in any extra renal infections, yet it is considered to be a harmful intervention, and that's why it was felt that we must look at non-antibiotic intervention that can prevent UTIs. And one such intervention is cranberry extract, where people need to do more studies to find out whether it can be useful. Thank you very much.
Thank you, Dr. Hari, for that very comprehensive presentation. We may have some questions at the end, so if you could hang around for some time until after the next talk. So our next speaker is Dr. Sriram Murthy.
Antenatal hydronephrosis, when do we need to act? So, okay, so the objectives of this lecture are to comprehend the spectrum of manifestations that encompass antenatal hydronephrosis. How do you postnatally evaluate antenatally detected hydronephrosis? And I'll be speaking through some clinical case-based scenarios illustrating the workup of antenatal hydronephrosis. So these were the last guidelines. We are updating it right now, but these are the last guidelines, and most of the workup of these cases would be based on these guidelines. They were published in the Indian Pediatrics 2013 by the Indian Society of Pediatric Nephrology. So before starting with these, let us see some basics. The fetal kidney can be detected by about the 12th to the 15th week of gestation. However, the renal cortex and medulla are not distinctly differentiated from one another till the 20th to 25th week of gestation. The fetal renal length is based on gestational age, and it is a marker of the renal growth. By about 20 weeks gestation, the fetal urine accounts for 90% of the amniotic volume, although the fetal urine production begins at 9 weeks itself. So it follows that oligohydramnios at or beyond 20 weeks gestation is an excellent predictor of abnormal fetal renal function. So what is the optimal timing for screening of the kidneys? It is about 16 to 20 weeks gestation. So based on these, one of the guidelines mentioned in this particular document, which I mentioned in the previous slide, is that if antenatal hydronephrosis is detected, we recommend that ultrasound at 16 to 20 weeks gestation also include evaluation of lower risk urinary tract obstruction, renal dysplasia, and extrarenal structural obstructions. And it is also mentioned that we recommend that fetuses with antenatal hydronephrosis and a major structural anomaly or additional soft signs be referred to an obstetric unit with facilities for genetic counseling and prenatal testing. So we know that CACUTs account for about, congenital anomalies of kidney urinary tract CACUTs account for 20 to 30% of all the anomalies identified in the prenatal period, and their frequency is about 0.1 to 0.7%. They account for almost half of all the end-stage kidney disease cases, and early detection of CACUT by optimal antenatal screening is needed. There are diverse presentations of CACUT. One of the most important ones is antenatal hydronephrosis. The other presentations could be in the form of a urinary tract infection, hypertension, CKD, or an obstructive uropathy. So the spectrum of antenatal hydronephrosis can vary from just a transient hydronephrosis to some overt congenital anomaly of kidney and urinary tract. So the prevalence of antenatal hydronephrosis ranges from 0.6 to 5.4%. It is bilateral in about 17 to 54%, and additional abnormalities are occasionally associated. Antenatal hydronephrosis resolves by birth or during infancy in about 41 to 88% of cases, suggesting that in the majority of cases it is benign. But our objective is to also identify who are the people who actually require interventions, and so the interventions are actually required in about 4.1 to 15.4% of cases. And it is also known that the rates of VUR and UTI are several fold higher when you have a severe hydronephrosis. So it is important to distinguish infants with illness that require a long-term follow-up or surgery from those who are just a transient hydronephrosis that is benign, which requires minimum need for invasive investigations. So let us see some cases. You have a 7-day-old male baby who is brought for evaluation of, for postnatal evaluation of antenatally detected hydronephrosis. The birth weight is 3.2 kilos and he is delivered at full term 40 weeks. A review of the antenatal ultrasound records done at 35 weeks indicates that the right kidney was 3.6 centimeters with an anteroposterior diameter of 8 millimeters. The left kidney is 3.7 centimeters with an anteroposterior diameter of 4 millimeters. So there is no oligohydramnios, the bladder is normal, there is no urethral dilatation, there are no cysts, there is no abnormal corticomedullary differentiation, so it is maintained. After birth, this baby is brought on day 7 and we find that the right kidney is 4 centimeters with an anteroposterior diameter of 8 millimeters. The left kidney is 4.1 centimeters with no pelvic dilatation. So the antenatal ultrasound KUB findings are confirmed. There are no extrarenal features in this child. So what should you do next? So you find that the fetal length should be actually equivalent to the gestational age. This baby was born at 40 weeks. So 4 centimeters, that is 40 millimeters, is 4 centimeters, that is correct for age. But there is a mild hydronephrosis, 8 millimeters in the right kidney. The left kidney has no pelvic dilatation, so there is no hydronephrosis here. So what does the guideline say? The guideline recommends that antenatal hydronephrosis be diagnosed and its severity graded based on the anteroposterior diameter of the renal pelvis, and it is defined if there is more than 4 millimeters, more than or equal to 4 millimeters in the second trimester, or more than or equal to 7 millimeters in the third trimester. So this is how it is mentioned. So in the second trimester, it is mild is defined as 4 to 6 millimeters, while in the third trimester, mild is 7 to 9 millimeters, moderate is 7 to 10 millimeters, and 10 to 15 millimeters respectively in the second and third trimester, whereas more than 10 millimeter and 15 millimeter in the second, third trimester respectively are for severe hydronephrosis. So when you have a unilateral hydronephrosis in antenatal ultrasound, we just follow up with an ultrasound in the third trimester and do a postnatal ultrasound between the third to 7th day. While if there is bilateral severe hydronephrosis, you have to do a serial antenatal ultrasound every 4 to 5 weeks and then do a postnatal ultrasound. Whereas if there is any systemic malformation or additional soft sign, we have to refer to a specialized service providing obstetric services, fetal medicine services. So these are the renal abnormalities that we should be picking up on an antenatal ultrasound, whether there is any oligohydramnios, dilated or thick-walled bladder, calyceate dilatation, urethral dilatation, perinephric urinoma, keyhole sign, or loss of any renal parenchyma as suggested by cortical thinning, poor corticomedullary differentiation, increased renal echogenicity, or renal cysts. Apart from this, systemic abnormalities related to various other systems which are mentioned in this should be looked for. So the postnatal evaluation management it is recommended that all newborns with history of antenatal hydronephrosis should have the postnatal ultrasound within the first week of life. In neonates with suspected PUV, oligohydramnios, or severe bilateral hydronephrosis, ultrasound should be performed within 24 to 48 hours of birth. In all other cases, ultrasound should be performed preferably within 3 to 7 days or before hospital discharge. And it is also mentioned in this guideline that assessment of severity of postnatal hydronephrosis can be done also by the SFU, the Society of Fetal Nephrology guidelines, or the anteroposterior diameter of the renal pelvis, and we should evaluate for calicial or ureteral dilatation, cortical cysts, or enhanced renal autogenicity and bladder wall abnormalities. So the SFU is mentioned this way. So Society of Fetal Urology gives a grade of grade 1, 2, 3 and 4. This is more complex than the anteroposterior diameter of renal pelvis, which is fairly simple. 7 to 9 millimeters is anteroposterior of renal pelvis is mild hydronephrosis, 10 to 15 is moderate, and more than 15 is severe. So what do you do in this particular case? This case has a unilateral mild hydronephrosis. You recall that the right kidney size was okay, but there was 8 millimeter hydronephrosis. The left kidney does not have any hydronephrosis. So there is no ureteral dilatation. So what do? We just follow up with ultrasounds every 3 monthly. And in this case, it was observed that the hydronephrosis resolves at 6 months. So the final diagnosis in this case is a transient hydronephrosis. So in this study, where about 1,000 newborns were evaluated for hydronephrosis after birth, it was found that the overwhelming majority were transient hydronephrosis, followed by pelviureteral junction obstruction, vesicoureteral reflux, and vesicoureteral junction obstruction or megaureter. Multicystic dysplastic kidney was also seen in 4 to 6%. So after a case of transient hydronephrosis, let us see the second case. This is an 8-week-old male infant referred for evaluation of a right-sided hydronephrosis. The baby was active, breastfeeding well, afebrile. There is history of antenatally detected right-sided hydronephrosis, 18 millimeters anteroposterior diameter in the 3rd trimester, without any oligohydramnios. There were no dysmorphic features or other abnormalities. On examination, a renal mass was palpable in this child. The ultrasound was right kidney 5.2 centimeters with anteroposterior diameter being 24 millimeters. So you would recall when it is more than 15 millimeter, we would call it severe hydronephrosis. So the left kidney is okay. Anteroposterior diameter is only 5 millimeter, so it is not dilated. More than 7 millimeter as per the guideline is dilated. There are no cysts, corticomedullary differentiation is normal. There is no ureteral dilatation and the bladder is normal. The serum creatinine is also normal. There is no hypertension. So how do you grade the hydronephrosis? It's a severe hydronephrosis. How do we evaluate this child further? So the guideline mentions that we do a postnatal ultrasound towards the somewhere between the 3rd to the 7th day. It's not preferred in the first 72 hours, because what may happen is because of dehydration you may miss a pelvic dilatation. So you do the initial scan in the first week, after 3 days, and then repeat at 4 to 6 weeks. If there is no hydronephrosis, there is no intervention required, and you just need to follow up with ultrasounds. If there is mild hydronephrosis without ureteral dilatation, then we need to follow up with just ultrasounds. Whereas if there is moderate or severe hydronephrosis towards the right side, or a mild hydronephrosis with a ureteral dilatation, then we do a MCU. If the MCU shows a VUR, then you have picked up the diagnosis, you put on antibiotic prophylaxis. If there is no VUR, then to ascertain the cause of hydronephrosis, we do a diuretic renogram using EC or MAG3 or DTPA. DTPA is less preferred because the background is to kidney ratio is higher in DTPA. And if there is a lower urinary tract obstruction like a PUV, then you refer for surgery. So what do you do in this case? The only exception is when you have a bilateral hydronephrosis in a male infant, then you may need to do an early ultrasound within this first 72 hours for detection of PUV. Otherwise, MCU is preferred at somewhere between 4 to 6 weeks. So this case actually fits in with this guideline with the need for diuretic renogram. So what we did was the EC diuretic renogram was done, and you can see that the left kidney shows a rising curve. So this was actually diagnosed as a right-sided PUJO leading to severe hydronephrosis, and the differential function of the right kidney was 30%, left kidney 70%. This child underwent a pyeloplasty. So this case is a severe hydronephrosis with a palpable mass due to a PUJ obstruction, and this was picked up by a diuretic renogram. Now we see a newborn male infant referred for evaluation of anteriorly detected bilateral hydroureteronephrosis, the right kidney being 18 millimeters dilatation and the left kidney 15 millimeter dilatation. There is a history of oligohydramnios, and you can see the ultrasound, it shows a keyhole sign indicating that the bladder is dilated, and so you have a bilateral hydroureteronephrosis confirmed. And when an MCU was done, you find that the posterior urethra is indeed dilated, and you can see the bladder is in a very bad shape. It is totally irregular outline. It was found to be a trabeculated bladder later on a cystoscopy, and the creatinine in this case was 3.8 milligrams per deciliter. After catheterization, it came down to 0.8. This child underwent fulguration, and on follow-up, he still continues to show features of a secondary neurogenic bladder, which is being evaluated with urodynamics. So, according to the guideline, it is mentioned that we recommend that infants with lower urinary tract obstruction be immediately referred to a surgeon for appropriate intervention, and the surgery should also be considered in bilateral hydronephrosis or hydronephrosis in a solitary kidney showing worsening dilatation or deterioration of function. So till now we have seen a transient hydronephrosis, a pelviureteral junction obstruction, and a posterurethral valve. Now we see a 6-week-old female baby referred for evaluation of anteriorly detected hydronephrosis, APD being 18 millimeters without ureteral dilatation. However, when this child was evaluated at around somewhere between 6 to 8 weeks using a EC diuretic neogram, there was no uptake in the right kidney. Now this is very unusual for a pelviureteral junction obstruction. At such a young age, you don't lose function. So what did we do? We asked them to re-evaluate the ultrasound. So what we found was there were multiple non-communicating cysts which were not communicating with each other. So this is a common mistake. If the cysts are communicating with each other, then it's a hydronephrosis. Otherwise, it's actually a multicystic dysplastic kidney. This was actually wrongly diagnosed as a hydronephrosis. So this child is actually a right-sided multidysplastic kidney, and the follow-up will be with serial ultrasounds, and we explain to the parents that gradually this kidney will undergo involution. The second kidney did not have any hydronephrosis, so this child did not undergo an MCU. So the indication for MCU would be if you have a hydronephrosis in the contralateral kidney, or if you have a recurrent urinary tract infection, then perhaps you would do a MCU. At follow-up, the right kidney involuted at 10 months, and there is compensatory hypertrophy in the left kidney. And now we have a 2-month-old female infant. She presented with fever 104 for 48 hours, and she is found to have urinalysis showing 200 pus cells per high-power field, and nitrite and leukocyte esterase are positive by dipstick. Serum creatinine is normal. She has stage 1 hypertension, and you can find that both the kidneys have hydronephrosis, the right kidney being 13 millimeter and the left kidney being 9 millimeter. So there is moderate hydronephrosis in the right kidney, and there is mild hydronephrosis in the left kidney. Ureteral dilatation is present in both the kidneys, and bladder is normal. There was history of antenatal hydronephrosis, and so it was 12 millimeters and 9 millimeter respectively in the 3rd trimester. Corticomedullary differentiation was normal, and bladder was normal. There was no oligohydramnios. She had been originally advised to just manage with ultrasounds 3 monthly, but now she had come with a UTI with E. coli 10 to the power 5 colony forming units per ml. She was given parenteral antibiotics for 10 days. So what do you do next? We will undergo a micturating cystourethrogram, MCU in this case, because according to the guideline, if there is unilateral or bilateral hydronephrosis with a renal pelvic diameter more than 10 millimeters, or SFU 3 to 4 or ureteral dilatation, then we will have to do it. So this child, you can see the MCU. MCU shows a grade 4 VUR on the right and the grade 3 VUR on the left. DMSA was done, and this showed multiple areas of deficient isotope uptake coinciding with renal scars. So the child actually has bilateral vesicoureteral reflux with reflux nephropathy, was given cephalexin prophylaxis. She continued to have recurrent urinary tract infections despite antibiotic prophylaxis and therefore underwent a ureteric reimplantation at 1 year. She is on antihypertensive drugs for the hypertension secondary to scars. So antibiotic prophylaxis, according to this guideline, is for all people. I know the guideline has changed now, but according to this guideline, it was actually supposed to be given throughout the first year of life for low-grade VURs and high-grade VURs up to 5 years. Now the guidelines have changed. So apart from this, postnatal evaluation and examination of extrarenal features in these children is very important. You can see polydactyly, you can see a coloboma, preauricular tag, or a branchial cyst. These kind of abnormalities you should definitely look for, and you should palpate the abdomen for any masses. Look for any palpable bladder after voiding, any deficient abdominal wall musculature in these children, which suggests a Poon belly syndrome, undescended testes, dysmorphic features or syndromic associations. Pulmonary evaluation is very important in the neonatal period because secondary to oligohydramnios, they can develop a pulmonary hypoplasia, ear abnormalities or a single umbilical artery. Any features suggestive of a Bacterl or a charge association should be definitely looked for in these children. Although in a mild transient hydronephrosis, these may not be relevant, but this may be more important for the more severe forms of hydronephrosis. And then of course, needless to say is we should follow up the anthropometry and the blood pressure in these children. So this is one of our studies published in Indian Pediatrics, in which what we found was out of about 314 children in whom we enrolled about 307 children with congenital anomalies of kidney and urinary tract, 80.4% had been identified during the antenatal period and 33 were detected after evaluation of UTI and about 6.8% after evaluation of hypertension. So it is needless to say that since 80% of these are identified in the antenatal period with antenatal hydronephrosis, so we have to follow them up using a standardized protocol. So my take-home messages are antenatal hydronephrosis can be a manifestation of a congenital anomaly of kidney and urinary tract. For example, a pelviureteral junction obstruction or a vesicoureteral reflux or a posteriourethral valve. It is important to distinguish infants with significant illness that require long-term follow-up or surgery from transient hydronephrosis that requires minimal need for invasive investigations. Diagnostic and therapeutic interventions should be considered for fetuses with suspected lower urinary tract obstruction and oligohydramnios at specialized centers following one-to-one counseling. Termination of pregnancy is not recommended in fetuses with unilateral or bilateral antenatal hydronephrosis except in the presence of extrarenal life-threatening abnormality. And if you have a unilateral mild hydronephrosis without ureteral dilatation, then you just need to follow up with ultrasounds every 3 monthly. But if you have a mild hydronephrosis with ureteral dilatation or a moderate or a severe hydronephrosis, then you need to follow up these children using investigations judiciously, such as an MCU or a diuretic rheogram. Thank you.
Thank you, Dr. Krishnamurthy, for an excellent presentation and within time. Now we are open for questions. So anybody has any questions?
Mike? Come to this side.
Hello. My question is to
I have a question to Dr. Hari. As you have mentioned that primary extracts can be an alternative to antibiotic prophylaxis. How young children could be, it has been tried to how young children and is it available in the syrup form at all? Or?
So there are limited studies on the cranberry. So there are limited number of studies on cranberry extracts, and more importantly, it's the availability of the extract. Because the juices that are available, you don't know what is the active ingredient in them. So you need at least 36 milligram to 72 milligrams of active ingredient for it to be effective. So that's why whatever extracts are available with D-mannose, they are for older, and urologists are using it. So they may be tried in older children, but then for younger infants, yes, there is no syrup available. So I mean, this is not a very standard therapy as of now, but it needs more testing and even the formulations are to be figured out so that it can be used if necessary.
My question is to
the syrup
Professor.
is available now.
Achha.
It comes with the name of Clear UTI. And
Okay.
it is actually a cranberry syrup. It's not a drink. It's a extract of cranberry and it's available in the market.
So does it also mention the active ingredient in it? How
Yeah.
many ml contains how much? Because otherwise it's not
Yeah, it is
effective.
recommended that 10 to 15 ml can be given diluted in a cup of water because it's a little sour in taste. And it's like a capsule cannot be swallowed for younger children. I have been using it and it's very palatable. But exact amount I'll have to see.
Because in the capsules also they don't write exact amount. So we don't know even if the syrup contains the right amount.
Syrup is because 10 to 15 ml I have
They
calculated the dose.
dose.
It comes to about 10 to 15 ml for the. And about Dr. Krishnamurthy, you are there? Okay.
He has just left, his flight will be going.
About the hydronephrosis, when the dilatation is less than 10 millimeters, we call it as mild. And the guidelines say 3 months, but I think we should get a repeat ultrasound at 1 month or 4 weeks. What we say is 4 days, then followed by 4 weeks if it's a mild hydronephrosis. And for little moderate or severe, of course, we have to get it earlier. But waiting for 3 months sometimes may be a little late, or even a mild hydronephrosis to be followed.
I think 3 months is a reasonable time, because if you are worried about the patient is not going to come back, that's a different thing. But otherwise, you generally would not do an intervention before 3 months of life. Typically, the interventions are required for PUE, which is very different.
And practically, we have seen that child can be 7 millimeters, at 1 month it becomes 12 millimeters, and the parents are worried if we wait for 3 months, it may become 15 millimeters. And
till the function declines, it doesn't really matter in neonatal hydronephrosis.
Function
It's
we will be
reversible.
able to see with
It's
DDT
reversible.
only.
Yeah.
So we can discuss it over the lunch.
Sir, I have one
In the
question.
faculty
Can we extrapolate our analysis of grade 1 to grade 4 VUR to grade 5 VUR, which we have not studied ethically till now, but probably with this data of grade 1 to grade 4 VUR, we can probably study further. And one more question. Sir, 50 years back, renal scarring was chronic pyelonephritis. And then probably the time came when it was called as that this is probably sterile reflux which is going on. And now evidence, and probably your talk also mentioned that it is renal dysplasia actually. So my question is, can we safely say that all the scars are renal dysplasia, or there is more to it now also?
No. It's not that. There are two kinds of scars. One that are large and result in contracted kidney are the congenital dysplasia. There are still small scars that can be acquired after a UTI, so don't forget that. But those are generally small and they generally are innocuous and may result in hypertension, but at very later age, but they do not really cause end-stage kidney disease or CKD. But you have to be careful with UTIs, you can still develop new scars.
Grade 5 VUR.
Yes, because generally we say that 3, 4 and 5 would behave in a similar manner. You are absolutely right till you have a direct evidence in 5, but in the last predict trial they included grade 5 and generally the 4, 5 behaved similarly.
So we would like to conclude the session here. Sorry for barging in.